that was also a small minority, though only 3%. In conclusion, the study reveals that conventional modes are limiting their ability to provide synchronous ventilation in premature babies, and it shows that now improves patient-ventilator interaction in premature babies. Thank you very much.
Any questions?
Christopher, thank you very much for this nice presentation. I have just a short question. How can I have wasted efforts during NAVA? Do I set the trigger very high? I mean, it's...
The wasted efforts that you see during NAVA is actually not NAVA. It's something called NAVA PS. It's pressure support.
Okay.
Because the mode in these little babies goes into this mode frequently. But as I said, like, I mean, everything we talk about here as NAVA, I mean, I feel it's a little ambivalent here because we compare, like, what controls the ventilator during NAVA is DDI. We use that as our golden standard in order to say what synchrony is. And then we compare the golden standard to anything else and say the golden standard is better, and of course golden standard is better. So I mean, it's as you say, Theo, it's like what doesn't work with NAVA, that's more what we should work on, because you should have everyone smack in the middle all the time. So again, it's a very good point. And as I'm saying, like, every baby has some diseases that you have to go through. So if this is measles or whatever it is, I don't know. But I think that NAVA will improve for that.
Where was the flow trigger was located in the conventional mode? Was it near the ET tube or was it near the machine?
Oh God, this flow trigger thing, I cannot answer. Pradeep could have done if he could have made it here, but unfortunately he got problems, so he could not come. I don't know in this study, but I can give you a good story about it, because you look at flow trigger, the more sensitive you get to trigger on flow, the more auto-triggering you get. The more pressure trigger you put back, like so that you go the other way, the less auto-triggering you get. But in that case, you get wasted effort. So what do you want, the plague or the cholera? I mean, choose. But as I'm saying, the game here is that you move one way, you get one problem, and improve one problem, but you increase the other, and then you go the other way, you take away that problem, but increase the other. So to me, it's like, as I say, I've seen this, I mean, I think like Laurent Bouchard gave the best comment, like during, like we had on some session and we talked about now he said, like, I mean, what are we discussing about? There's no discussion. I mean, pressure support works perfect in, I would say, 50 to 75% of the patients. But when it doesn't work, what do? We asked these guys in New York, turn the knobs, do everything you can. They turned the knobs, they tried everything, nothing helped. So, I mean, to me, I think it's more like to say, it's more like we have to decide a little bit when to use it and what patients and what are the indications. I think that's the real things. The thing that it works, I don't think that's it, that it has certain limitations. Every mode has limitations. But it's not so much to focus on this, it's much more to focus on the real thing, and that is like, I think, as I agree with Jukka there, it's like we have to go and say, what do we want? We can't just like say that synchrony by itself is anything, because you can show synchrony with like asynchrony that is the worst, but if a patient is over-assisted, then you will affect the diaphragm. It doesn't hurt the lungs. If you give too high volumes to a patient because the patient is like having like other efforts, you have hemodynamic problems and so on, I think we have to decide a bit. Like, and I think this meeting is a great place to discuss this.
Okay, thank you very much, Chris. I think these graphs might be really helpful in clinical care. I mean, it gives you a very nice picture, but there's something I don't really understand. So can you explain once again, what's the difference between early cycling on and a wasted and auto-triggering?
Early triggering or auto-triggering or yeah.
Early cycling on and auto-triggering, yeah.
What Leo is aiming at is that we took the definition here to say, to define what is relatively an early start of a breath. It is that we say that from the previous end of an inspiration to the start of the next inspiration, the machine actually starts there. And I mean, that's what you normally would call an auto-triggering. But because it actually cycles off in the right cycle, we bring this in to say we can define this as a too early start, but a more normal cycling off. So it's again a definition problem. And we tried with this index to make something that should make it like, what we want here is like not so much to fall like off the screen, because then you start to count wasted efforts and so on, and that's easy to do. The thing is much more here when you are throwing dart. I mean, the one who gets their arrows hanging in the curtains in the next room, I mean, it's not a dart player. That's not what the game we play. I mean, you should be on the board and you should know where on the board you land. So if you talk about synchrony, you should at least be on the dartboard, and that's, I think, what we did with this index.
Thank you, Chris. Are there any more questions? Yes, I think there's one. It's the microphone.
Chris, I have a question, but maybe I am wrong. Correct me if this is the case. Most part of wasted effort during pressure support are related to large tidal volume preceding the wasted effort. I'm correct?
Correct, yes.
Reducing pressure support may reduce the tidal volume and reduce wasted effort. During NAVA, let's suppose a large tidal volume, and during the expiration, electric diaphragmatic activity that will lead to another breath. Is this breath, which is not a wasted effort by definition, is it good for the patient or no? May this breath increase, for instance, gas trapping? Maybe I'm not, my question is not clear.
Oh, I think I understand what you're saying. It's a very good question, and again, I think we come back to the issue about double triggering. And if you, of course, take a big breath, and then you stop it, and then immediately start another breath, well, it's not the thing that you start at the breath that is so much of a problem, because the only thing, if you start a breath and deliver very little pressure, you will not do anything more than to obstruct the expiration. You will not inflate further. It's only in volume control that can happen. All other modes would either give equal pressure or lower pressure. So the same pressure, again, will not increase your volume any further. It will just prolong the time it takes for you to breathe out, which will affect the hearing-Breuer reflex, and you will get the longer exhalation period. I think, in that sense, I think that it's harmless to see double triggering. Double triggering is a very low % of breaths generally, except in ARDS patients on volume control. But otherwise, I think it's not a big issue. I think another issue rather is what we should be aware of with NAVA is when we talk about treatment of COPD patients with the same thing, that when the CO2 level is high, the drive is very high, and you pump away, you have a very high respiratory rate, even if it's at a low EDI, you could turn up the NAVA level a bit. That is that you might get hyperinflation that way because your neural respiratory rate is so high, but your expiratory time constant is so low that the equation doesn't meet. So you create so in a status asthmaticus patient, for example, I don't know if NAVA is recommendable. But if you say a moderate to relatively severe COPD, I think it's probably, most people have very good experience with those. But if it gets really severe and very, very difficult expiratory flow limitation, then again, I think that chances of a hyperinflation is in that sense a problem. And then it might be better to switch to pressure support and waste every second effort, and you give them some expiratory time.
Okay, we have time for one more question, and then we'll have a break.
My question is about the pressurization slope, because in fact in most studies the pressure may vary a bit between the different modes, but not so much. The tidal volume are rather same, but the pressurization flow or slope is very, very different in NAVA as compared to other modes. or most of them have decelerating flow, and in NAVA it's a low constant flow or even an accelerating flow. What is your impression of the impact of that, and particularly on air improver reflex?
Again, I think, accelerating, decelerating flow rates and so on. I mean, I think the thing is you have to know what you want to do with your ventilation. And I think in the adult patients it might be very reasonable to talk about this, but in a premature baby with respiratory rate of 60, I think you are just running a race so fast that you should just be happy that you keep up with them. I think that's really one thing. And the thing is also here, I mean, these babies respond to the increasing assist. They will downregulate their drive. They have a very strong hearing body reflex, so they're very lung protective. They are also protective to deflate the lungs. I mean, we have shown that if PEEP is taken away, we get tonic activation, and they almost all carry tonic activity. So I think in the end that it's seen now as an additional muscle. It's not anything where you would go in and modulate focus. This is exactly, how would you breathe? Do you breathe a sigh? Is that a decelerating flow, or is it an accelerating flow, or is it a constant flow? I mean, when I take a breath between I'm speaking, I mean, I'm just taking a quick breath in. I mean, so air goes in and out if it has a certain profile. I think this is the old paralyzed patients kind of ventilation that we're talking about. I don't think we talk about spontaneous breathing assist. I think spontaneous breathing assist is not in that area. We can, of course, set a neural trigger and a neural cycling off and make Paulus super NAVA. And we can have a decelerating pressure or what we want.
But in fact, I wonder if the difference in the flow pattern does not explain the impressive effect on certain patients who are not ventilated, in which we are not able to ventilate them in conventional mode. And when we switch them to NAVA, the pressure drops to maybe sometimes by 10 points. And the Asynchrony does not explain on this, only the Asynchrony cannot explain such a drop. And I wonder if it's not because of the lower reactivity of the air improver reflex with a slower rate. I don't know.
I think one thing we have learned in regards to NAVA is that when you talk about premature babies, NAVA is actually cycling off a little bit too late. 70% is actually a little bit, because they have a very short time constant. So this flow starts very, very early. So soon as so when you pass the peak of DDI, boom, it falls. But in the reverse, they very often have a breathing pattern that EDI goes up like this and then goes down very slow, instead of usually it goes up a bit slow and then down fast. So again, we are in this thing, but it's as the same thing as the plateau period in volume control. You can reduce the amount of Pendelluft, you can have a better gas exchange if you have a little plateau at the end. We showed in rats that this is really the case. So in the babies, like we did not intend that it should be so, it just so happened, but it seems to actually have a little positive effect. And I think on the other side, in the adult, that's where maybe one would have to discuss, maybe one should have a little bit delayed trigger sometimes. But that still remains to be evaluated. Thank you so much.
Thank you.